Welcome to this explainer. Look, if you're navigating the maze of complex neurological diagnoses, you already know that normal pressure hydrocephalus, or NPH, is one of those conditions that demands absolute precision. Today, we are breaking down exactly what symptoms define this condition, and, just as importantly, which ones explicitly rule it out. We're going to go point by point through the clinical profile, ensuring we do not skip a single critical detail so you can lock this concept down completely without feeling the need to constantly reread the textbook.
To make sure we don't miss a thing, we're going to hit 6 key areas today. We'll start with the classic clinical triad, then unpack the gait disturbance, look at dementia and urinary incontinence, compare Alzheimer's to NPH, touch on other notable features, and finally, look at symptoms you definitely shouldn't expect to see here.
All right, let's jump right into Section 1. The classic clinical triad.
So you probably already know the triad: gait disturbance, dementia, and urinary incontinence. But here's the catch. These features are absolutely not pathognomonic to NPH. You're going to see very similar, overlapping symptoms in vascular dementia, Alzheimer's, and Parkinson's. And that is exactly why we need to put these 3 pillars under the microscope and look much closer at their specific characteristics.
Which brings us to Section 2, unpacking the gait disturbance.
Now, this is fascinating. Almost all NPH patients experience what we call a magnetic gait. When they try to walk, it literally feels to them like their feet are glued to the floor. Imagine trying to step forward with magnets on your shoes. It creates this really profound, visible struggle just to initiate a step or start a turn.
Beyond just that initial feeling of being stuck, if you're watching an NPH patient walk, you'll notice a few classic signs. They'll typically use a wide base stance to make up for their poor balance. You'll see these short, shuffling steps. Turning is especially tricky for them, often taking multiple really careful steps just to pivot. And watch out for retropulsion, which is this tendency to fall backward. Obviously, this leads to frequent and pretty dangerous falls.
But here's a really key clinical distinction to remember. Even though their walking and balance are severely impaired, these patients characteristically do not have appendicular ataxia. So if you have them sit or lie down and do a finger-to-nose test to check their limb coordination, it's actually completely fine. The glitch is isolated heavily to the mechanics of their gait and stance.
Moving right along to Section 3, dementia and urinary incontinence.
The type of dementia we see in normal pressure hydrocephalus is quite specific. It's mostly characterized by memory impairment combined with bradykhrenia, which is just a clinical way of saying a distinct slowness of thought. You're also going to see bradykinesia, or slow movement, along with a heavy dose of apathy, lack of motivation, and excessive daytime sleepiness. These are traits NPH actually shares with a few other frontal subcortical disorders.
But let's get really precise here, because knowing what is absent is just as crucial. Patients with NPH dementia typically do not experience expressive or receptive dysphasias, meaning their foundational language skills are intact. They don't have dysnomia, so they can still name objects. They recognize familiar faces perfectly fine, and they absolutely do not hallucinate. If you're seeing those symptoms, you need to be looking at something other than NPH.
Okay, let's look at the third part of that triad, incontinence. In NPH, this isn't just a gradual, casual loss of bladder control. It typically hits as a sudden, intense urinary urgency, paired with the physical inability to stop the bladder from emptying. They feel the intense need to go, but the neurological brakes to hold it back just aren't working.
And there's a vital caveat here regarding awareness. If your patient is completely unaware of their incontinence, like they're voiding without even realizing it's happening, that is a massive red flag. That complete lack of awareness points away from NPH and strongly suggests a totally different kind of dementing process is at play.
All right, Section 4, Alzheimer's disease versus NPH. This watercolor-themed table here is a fantastic breakdown. It isolates exactly how the cognitive deficits in Alzheimer's differ from those in NPH, line by line. By comparing things like memory, executive function, and psychomotor skills side by side, we get a really solid roadmap for a differential diagnosis. Let's highlight a couple of the biggest takeaways from this.
The first major contrast is memory. Alzheimer's, as we all know, is notorious for severely impacting general memory. It's a very distinct, profound impairment. But NPH, it's much milder in this specific domain. With NPH, you're usually only going to see borderline issues, and specifically with auditory memory.
On the flip side, let's look at physical and processing speeds. Alzheimer's normally just shows borderline impairment in fine motor speed, especially early on, but NPH takes a massive, obvious toll here.
It distinctly slows down both fine motor accuracy and overall psychomotor skills. That overarching slowness is a huge defining hallmark for NPH.
Next up, Section 5, Other Notable Clinical Features.
Demographically speaking, NPH is a condition that generally shows up after the age of 60. And if we look at the stats, there is a slight male preponderance, meaning it leans just a tiny bit toward affecting men more frequently than women.
When it comes to speech, if your patient suddenly gets quiet, you really have to understand the underlying cause. True aphasia, actually losing the ability to understand or express speech, is incredibly unusual here. But you might notice their overall speech output drops off a cliff. Why? It goes back to that profound apathy and low motivation we talked about earlier. And keep in mind the progression. Without intervention, this cognitive impairment doesn't just stay neatly confined. It generalizes and gets much, much less responsive to treatment over time.
We also absolutely have to talk about comorbidities. Believe it or not, about 11% of NPX patients present with symptoms that look completely identical to idiopathic Parkinsonism. Plus, the literature is full of psychiatric disturbances linked to this. Case reports show everything from severe depression and bipolar disorder to really surprising bouts of aggressiveness and paranoia. NPH can cast an incredibly wide net over a patient's behavior.
And finally, Section 6, Symptoms Not Expected Here.
Sometimes the best clues are the ones that tell you you're barking up the wrong tree. The presence of common, everyday neurological red flags actually means NPH is probably not the culprit. So, if your patient is complaining of headaches, or if you see papilledema, seizures before they've had any surgical shunting, spasticity, hyperreflexia, or any lateralizing findings that affect one side of the body differently than the other, you need to stop and reconsider. These features are totally unexpected in NPH and point heavily toward alternative pathologies. So, we've walked through this point by point, skipping nothing from the core material. By knowing exactly what fits this clinical picture, like that glued-to-the-floor magnetic gait, and exactly what doesn't, like true aphasia or headaches, we're left with a really profound question. How many patients out there could literally reclaim their minds and their lives if we just looked a little closer at the nuances of their gait and memory, rather than just settling for a misdiagnosis of Alzheimer's? It really goes to show just how powerful structured, precise medical knowledge truly is. Thank you for joining me for this explainer, and I hope this breakdown has completely cemented your understanding of NPH.